beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the retina world community.
Tarek, please, go on.
Hello, I'm Tarek Hassan, President of the Retina World Congress, and I'm very pleased to welcome you to another edition of RWCE Live. It's a wonderful educational event that is truly uniquely planned. It's a program created by the world for the world. And today we have thought leaders from across the globe who will share ideas, tips, tricks, videos, and interactive discussion about so many important topics in retina that will ultimately help us take care of our patients better. In this strange time that we live in where we can't meet together at congresses around the world, we still can share ideas, and the Retina World Congress in particular unites societies and retina specialists around the world so that we could all continue our wonderful educational path in our field of retina. Today, we're very pleased to welcome thought leaders from literally every hemisphere. We have the All Indian Ophthalmologic Society helping to sponsor this event today. We have the Uruguayan Vitreoretinal Society and the Arab African Retina Society as well, and the Cairo Retina meeting. So we want to thank all of them in advance for their participation, and I want to turn our moderation over to George Rocha, who is the Director of Communications at the Retina World Congress. George?
Hi, everybody. I'm very pleased to be here with you more one time. We are now in our 5th edition of Retina World Congress eLive, and today we gather a very good team, a dream team of retina. They're gonna share very important informations and education points from vitrectomy in retina. Today we have Sandara Nataranjan from India. We have Maria Berrocal from Puerto Rico. We have David Shaw, represent Canada. We have Miguel from Uruguay, South America. We have Ehab from Egypt, and we have Carlos Mateos from Spain. I'm very happy to have all you here. That's very good to get together in these dark times and have the opportunity to share with the world this information, knowledge, and most of them, the feeling that we are very near, very short to finish this and get together live and to celebrate. Please, today we're gonna start with my friend from India, Nataranjan. He's gonna share with us a very good video and very good talk. Please, Nuti, it's all yours.
Yes. Good morning to all my friends in both North America and South America, and good evening to India and this part of the world. And thanks to Tarek and Debbie and the Retina World Congress for having me. I'm just starting my presentation. My talk is on managing complex ocular trauma. and also expulsive hemorrhage. So here is the first video. Can you see my screen?
Not yet.
1 second, I think. Yeah, sure. You can see the screen?
Yes, we can see.
Yeah, we can see.
Okay. So
Yes.
my first talk video is on pellet trauma, where it was happened in 2016 after there was a killing of a skeleton. And here I see a Afiki Kai with a 3-port pars-plana vitrectomy in progress. So I actually make a 11 to 1 a few millimeter incision on the conjunctiva and sclera, and directly grasp the with a 4-pronged forceps, which we, myself and my colleague, Dr. Manish Papai and Mahesh have designed. And we remove it through the 12 o'clock meridian, which is easy to approach. And then you can see the corneal suture and the aphyceal. So, and after closing the scleral wound and the conjunctival wound, we proceed with the 23 gauge vitrectomy. And you can see the vitrectomy is in progress. I don't allow the pellet, which is engulfed in the vitreous hemorrhage, to fall on the retina, just to avoid iatrogenic trauma. The vitrectomy to vitreous base excision. At present, clearing the exit wound just close to the optic disc. Fortunately, had a run through injury from that, but not injured optic nerve, and doing a laser around that exit wound and creating like a coloboma choroid around the disc region. Since the muscle has bad, I think the patient later underwent a secondary transplant and got almost 6/9 vision. I know all the trauma patients do not get this. And this is a other patient who had a cataract with a corneal wound repair done, a vitrectomy, cataract with IOL, with vitrectomy, with submacular drainage of the subretinal blood was done. And you can see the post-op picture 6 weeks later, a retina attached and the silicone oil is in situ, and later we removed. And this was another injury with a bamboo stick. So it was a 40-year-old male with a history of assault by 8 people. And he reported with no perception of light in the right eye, and investigation like CT scan was done. He was advised evisceration elsewhere, and then he came to me, and there was a plan either to eviscerate or reconstruct. We explained to him the risk of sympathetic ophthalmia, took a video consent, and then I followed my philosophy. Eyes with no perception of light we should be always undergo a primary repair, even when the anatomical success is as poor as less than 1%. He was planned for the right eye primary scleral tear repair with the intravitreal antibiotics. You can see the conjunctiva periptomy was done. The scleral tear was exposed, and 15 days later, you can see the eye was quiet. And then what next? So we planned for a 23 gauge pars-plana vitrectomy, and you can see we use the AC maintainer to start with. So clear the anterior hyphema, made a 6 o'clock iridectomy before we go in with the vitrectomy procedure. So then after that, we can see the eye is getting cleared with a 3-port with the AC maintainer and 2 ports for the right. And you can see the inferior part of retina had a total giant tear, and at present you are clearing the subretinal hemorrhage, which is plastered to the choroid using the retinal brush. And you can see the folded retina, which is coming anteriorly. And I think the inferior retina is incarcerated in the superior wound. And if you have seen, remember the wound repair, the scleral tear was on the upper part. And you open up the fold, and you can do the illumination using the channel illumination, and then open the fold, use perfluorocarbon liquid, and you can see you are clearing the blood which was there in the subretinal space. And under PFCL, you can see the endolayer being done to the giant retinal tear, where it was separated from the superior half and placed back. And you can see and after that we actually do the PFCL oil exchange, and I leave the air in the antechamber, and then patient we had used Denziron, and there's no financial interest. I use Denziron a lot as a heavy oil, and at the end of 3 months I remove the Denziron. And then we have this is an eye with the after an injury had a severe corneal infection, and you can see the temporary cataract process is being placed, and then my corneal surgeon Dr. Kavita Rao does the airtight watertight suturing of the temporary cataract processes. And then this is I used a 20 gauge infusion line and a cutter. The reason is you can see the vitreous was full of exudates like a phlegm. It was thick, so I used a 20 gauge cutter to clear all the. You can see we're patiently removing, and after clearing the vitreous, you can see the optic disc. The eye is clean, and then used keratoplasty. And usually the cornea may get opaque, and then later we can replace and do a optical keratoplasty. And then this was another road accident case where he had a total funnel retinal detachment. So at present, you can see the total retinal detachment. Again, the nasal temporal retina was incarcerated to the, and you can see the total detachment, which is like a flower with a PVR D3. Now I'm using the illumination and using bimanual instruments, 2 forceps, and opened up the fold, injected the perfluorocarbon liquid on the optic disc. You can see the retina is totally attached, and now separating the fold and doing 360-degree laser. Took about 3 hours, and it's a video, and you can see you can salvage an eye which was referred by the other hospital inoperable case. And you can see the post-op, pre-op picture with the corneal suture going from 12 o'clock to 6 o'clock, and then you can see the attached retina in the bottom with the post-op picture. So I'll open up the other presentation. So that's on the choroidal expulsive hemorrhage, where a 76-year-old male who had a post-open globe injury, post-primary repair, and with an aniridia aphakia reported to us. And you can see I'm opening the conjunctiva. And then tagging the muscle carefully. And I actually keep the infusion through the AC maintainer to maintain the intraocular pressure. So that, and I also placed a 240 band using the scleral flaps. And you can see this patient, he actually came post-corneal wound repair, about 24 hours later. And I think I took the second surgery in about 48 hours. And now I'm entering with a 23 gauge. And while doing the vitrectomy, I faced with expulsive hemorrhage. In spite of all the experience, and this is a learning, and suddenly there's a mound happening, and I didn't realize it was an expulsive hemorrhage happening, even though it was a controlled with all the pressure control. And I thought first the infusion line was slipped, and then I tried checking. In that time, probably a few seconds I wasted, and by the time I realized what's happening, it was an expulsive hemorrhage, and then I had to suddenly decide to use the perfluorocarbon liquid, silicone oil, and then to stop the hemorrhage. And and you can see where I'm increasing the intraocular pressure to 60 for a few seconds, and then I finally remove the encircling band, close the wound, and then I take the patient after 15 days or 18 days for a resurgery, and you can see this eye, and actually there's no vitreous. So at present, when I do the first entry with a 23 gauge trocar cannula and do a vitreous lavage, you can see the heavy oil behind, and the vitreous hemorrhage was just a fluid state. So I did a vitreous lavage, cleared all the blood which was in the anterior surface, and the posterior part was with the heavy oil. The only thing was there was a retinal detachment, and the heavy oil was behind the retinal detachment, and there was a large temporal tear and a macular hole. You can see there's a large tear, and I'm going through the break into the subretinal space, clearing the vitreous hemorrhage, also doing a vitreous base excision and some clots which is there. And then I go through the subretinal space and do the vitreous lavage, and you can see the something like a you can see the edge of the heavy oil, because heavy oil settles down, and then I use a viscous fluid extractor to remove the heavy oil. You can see the like a golden ring, which is seen as the last part of the heavy oil is being removed. And so I think the problem is to remove the heavy oil, and that too which settles down posterior. And now using the retinal brush to clear the subretinal space of obviously blood, now opening up the fold, and then clearing the vitreous. And then I do repeated fluid air exchange. Since I know there is a macular hole, I didn't use PFCL in this eye, because I know that it will go in subretinal space and sometimes it can get in the nasal part. So I decided to open up the fold using the repeated fluid air exchange, working under air to separate the folds, and then removing the clot using the forceps, and then also pushing. You can see now I'm going through the macular hole and doing a fluid air exchange. You can see the retina is getting settling, and slowly the whole retina gets attached, and the macular hole is a little bigger. So I went through it gently without damaging the edges of the macular hole. And the reason was to drain all the subretinal fluid posteriorly, because otherwise sometimes some pocket of fluid remains. And I did a fluid heavy oil exchange, and 3 months later did the oil removal. And this is the fundus picture. We can see the endo laser done around the macular hole as well as the peripheral break. Only because of the PVR, I decided to do a laser around it. I know many people will not agree to it, and the reason was to keep the retina attached. And he is already a 85-year-old person with the other eye 6'6", but I used it as a spare tire. This was a 72-year-old one-eyed patient who was undergoing cataract and developed the expensive hemorrhage. And the senior cataract surgeon called me and asked me, what do I do? I said, you close the eye and send the patient. I manage the intraocular pressure, the inflammation, and then I took about a week to 10 days to make sure ultrasound shows the blood is liquefied. And I also do external drainage. I usually drain the subretinal suprachoroidal hemorrhage through the ports, and then you can see I'm doing the which is anterior vitrectomy through the AC, and this is what I do in many cases. The reason is because many times you don't know because of the suprachoroidal hemorrhage, whether your instruments are in the suprachoroidal space or in the vitreous space. So I think first I make sure the peripheral part, the pars plana region is clear, and then make the 3-port, and then continue with the vitreoretinal procedure and do all the vitreoretinal armamentarium, do a thorough vitrectomy, vitreous base excision, and then use the PFCL. Even if there's some suprachoroidal hemorrhage, it can drain through the sclerotomy, which I've done. And now I'm opening up the folds, and you can see the vitreous is in spite of the she's a 70+ years old patient, the PVD was not there, and it took time to induce PVD and remove all the vitreous. And then it took a long time, but I think it was a one-eyed. So I did everything to make sure that we clear the vitreous, reattach the retina, and also do the endo laser in the peripheral break. And you can see at the end the disc was pale, but still this patient got about 20/200 vision, and with low vision aid she could read, even though she was unhappy that she couldn't read but I think the eye she would have lost. She had a perception of light and got about 20/200 vision. And then 6 months later we removed the oil, and she's still doing well. And this is another a patient who had undergone a penetrating keratoplasty. He had a penetrating injury. He was using a nail and poked his own eye. And then the suprachoroidal hemorrhage was done. So the video was not working. So this is another, okay. So I think I'm happy to now stop sharing. So thank you very much for the opportunity, and I wait for any questions and discussion. Thank you very much, George and Tarek.
That was quite amazing, Nadi. Thank you for showing us. Your results in your videos were really unbelievable. I feel like I've seen all of Retina already. I don't feel like there's anything left in the world of Retina to see more beautifully done than that. Really quite amazing. Nadi, your cases were really quite bad. Some of those eyes look very damaged. I think there are some specialists around the world that may not have even tried fix some of those. Can maybe you share briefly what your thoughts are? I saw you had a slide about your philosophy for no light perception, for no light perception eyes. How does one accurately assess those eyes that should be tried or not? Or are you saying that all no light perception eyes with trauma should be approached?
I think the International Society of Ocular Trauma, where Ferran Spoon heads, and I'm a part of the international board. And I think Fernando is here on the moderator. And I remember one of the child who had a no perception light in both eyes, and I took his opinion, and Ferran said there's no other alternative, and that this is just because the political issue in Kashmir, I took all precautions because she was in the newspapers all around, including New York Times, and I took a opinion and I did the surgery. I think the child got, she was a 12-year-old. She got from no perception of light to perception of light. So I think the lesson is they out of 100, maybe 10 may do well anatomically. Among them, one may have some useful vision. And I think the New York Times reporter asked me, is it worth spending hours to repair this eye? But I remember my teaching from my second mentor, Dr. Jovanovic. He said, each experience in a trauma patient with no peer will help another one-eyed patient if you are going to meet maybe an old man. And I think your experience will use. So that's the reason I've shifted from doing, I think, normal macular holes, scleral bucklings come to me. But even then, if it comes, I like to do it, including the primary repair. But otherwise, I like to do all these failed patients by elsewhere. I know it's a bad scene, and I think I'm like a little ray of hope for the people, for the surgeons in India, where in case they give up, and I tell them I can do a trial, not trial, I can do a surgery and see even if there's 1% chance, I'll do my best, and I think, and then leave it to the nature for the vision to come. But I think in my experience, after explaining the patient, taking a video consent to the family, there can be agitated patients when they lose vision in the agitations like this, the police firing or the army firing or in an assault. And I think if you explain to them well, with your reputation helps to control. And I also have counselors who counsel the patient. I think we have to be clear that only in trauma we should attempt no perception, right, and no other indications.
Nuri, this is Andre. Can you hear me?
Yes.
Hi, how are you? Beautiful cases and very complex cases too. This is tough, and you have a lot of experience when it comes to trauma. But we all know that once you're inside eyes like that, so you can end up with a masterpiece, or sometimes you don't get anywhere. So you plan as you go. But I would like to ask you, in case you have a combined massive suprachoroidal hemorrhage, what is your best approach for those eyes?
Usually, whenever the trauma pain happens with the open globe injury with the suprachoroidal hemorrhage, I do the wound repair first, and then follow up the patient in managing intraocular pressure, the inflammation. A week to 10 days, we make sure that the fluid, the suprachoroidal hemorrhage is liquefied, and then I use the 23 gauge, go posteriorly depending on the ultrasound where the mound is, and put the trocar halfway through, and then you increase the intraocular pressure mildly using the AC maintainer and also the cotton bud applicator to squeeze out the fluid. Usually it comes. And one of the video last didn't work. And actually I saw, even though waiting 2 weeks, the blood didn't liquefy and I had to squeeze out the clotted blood. But I recently saw my Japanese colleague who used TPA, waited for 45 minutes and then did a drainage, which I have not done. And I always feel better to wait for a week to 10 days, not more. And then in case that time, probably you can use a TPA a day before and then inject it in the suprachoroidal space and then drain the suprachoroidals totally.
Beautiful.
I just want to point out that the injection of TPA suprachoroidally was described by Marco Sago from Brazil years ago.
Yes.
And it really works. You inject it, and if you wait 45 minutes to an hour, then you can drain it. Wilmer and Hopkins is a trauma center, so we see a lot of these cases, but I think, Nori, you are the king of ocular trauma in the world. I mean, you have amazing cases and amazing results. I think you have shown cases that are in the pandemic time, an emergency, things that we're still doing every week here as well, and showed beautifully how to manage them. I think for patients that have ocular trauma, we have to be mindful that it is possible that they may develop suprachoroidal hemorrhage because these are patients that have hypotony, they have inflammation. So when it happens, yes, waiting a little bit with ultrasound monitoring for the clotting to lyse is the best way to go to then drain and give the eye a chance. And I also want to finally point out that Fuller years ago published a paper where he demonstrated that there are patients with no LP that do have recovery of vision, and some of these cases can be monitored preparatively with the visual evoked potential to determine which eyes can be operated on.
Yeah, but I Tarek and Fernando, I think any no perceptual light, I think that's why I recommend the last chapter by Steve Charles, Surgical Self-Education. I think every surgeon has to introspect, can I operate this? Am I equipped with experience and instrumentation? And then whether your team is ready, and then only do. And I don't have an ego. Sometimes I tell the patient, you can have a second opinion. I know that there's no surgeon senior to me in experience, but still I tell them, you can go to my junior colleague or any other center in India for an opinion. And if you all like, you can come back. The reason is, I think they're always in everybody's, every veterinary surgeon mind, is it worth operating? And I think 30 years back when I came to Mumbai, many times my colleagues tell, oh, Natarajan is operating for money. But I've proved now that I attempt, and I think with a clear understanding with the referral surgeon and the patient, that our aim is to repair the anatomically the eye instead of eviscerating or enucleating, and then do the best. I think even endophthalmitis, if it goes to panophthalmitis, definitely you have to eviscerate. But till the time the stage of endophthalmitis is there, I think however bad it is, with an organism like bacillus, we give the intravitreal antibiotic injection as per the dose. And then we try to first save the eye. I tell them it's like a fire in the building. We save the eye and then see whether there's a functional opportunity possible in the second course of time. I think some patients have undergone 4 and 5, 6 surgeries, depending on some corneal surgery, silicone oil injection, re-injection, removal, and maybe re-injecting to 5,000, exchanging the oil. I think we have to keep the sympathetic ophthalmia in mind. And I think when I had a multiple surgery, a young girl, I think post-vitrectomy, she had a sympathetic ophthalmia in the only eye, and she had 6/6 with the eye diagnosed at the earliest and treated as a bilateral uveitis with the antimitotic drugs and steroid, and luckily we saved. But I think we have to keep that in mind when you're going to do multiple surgery of sympathetic ophthalmia.
Hi, Nuti. Very nice. Congratulations. I love your case. And I have a question from the audience. Dr.
Yes.
Mustafa, they ask you how long you take from the primary intervention for the next one, if you have how you handle that.
Usually, I think the regular teaching was primary wound repair first day, and then have second repair in 14 days. And now recently, Ferenc Kuhn has published that it's better to enter the eye in the 6th to 7th day. So that's the philosophy I did in Kashmir, where I tell them, do the wound repair, do the first surgery within 7 days. So I think I recommend the second window should be the first week.
Okay, very nice. I love it. But we have so many good speakers now, and I have to thank you and ask Dr. Maria to approach his talk, because everyone is so good that I need to hear. Please, Maria.
Yes.
Thank you, George, and all.
Yes, thank you so much, George. It is really, I have to thank you and Tarek and everybody at Retina World Congress for bringing so many friends from the world together to at least meet in this way. Hopefully, we'll be able to meet in person sometime soon. So today I'm going to talk to you about some of the pearls that I learned along the way on how to manage diabetic retinal detachments. These are my financial disclosures. So I'm going to just tell you how I feel you can improve your success rate. There's some important things. Seeing well is key. You want to optimize your visibility. You want to control intraoperative hemorrhages because these eyes bleed a lot. You want to prevent iatrogenic breaks, particularly in traction detachments. You want to prevent and manage postoperative bleeding, which is the #1 complication of these cases. And if cases redetach, you want to recognize that early and manage it well. And traction and rhegmatogenous detachments that are combined really are the hardest, and they require special considerations. So improving the success rate, how do we, for some reason, the movies are not playing in this fashion. So I'm going to have to do it this way. So, so how do we optimize visibility? I like using wide angle viewing systems. 3D viewing is my preferred mode. I think a chandelier is very helpful, particularly in very difficult cases. It lets you see better. And if you're going to use bimanual techniques, that is key. And optimizing the cornea and marking iatrogenic breaks. This case on the right was a diabetic that actually had most of the pathology towards the periphery with a lot of traction of the vessels there. And as you can see there, there's neovascularization and a lot of fibrosis in the periphery. But it also has a membrane in the posterior pole, which I'm peeling, part of the attached hyaloid. And here I use the OCT beforehand. Many of these cases, you don't really know what's happening in the fovea, and the OCT is very useful to determine the status of the fovea, which gives you a better idea of what to use. An intraoperative OCT would be very useful, but I don't have access to that. So after I relieve all the traction, and what I like about the chandelier is that I can scleral depress myself. So I scleral depress, and then here I have freed everything, and I'm doing a fluid air exchange. I really prefer using gas in diabetics than silicone oil, although silicone oil is necessary in some cases. But the beauty also of the 3D viewing system is that you can really see well under air. Here's the view with a partial air exchange. So this case did actually quite nicely, and it was aided by all of these things. Another thing, controlling hemorrhages is important, particularly when we're doing surgery. I'm old enough that I remember when we had no good means of controlling hemorrhage, and we had to sometimes close the eyes because they, bled too much, and had to operate them later. So using preoperative VEGF inhibitors 1 to 5 days pre-op is key. I think it makes surgery much easier. I don't use it all the time, but I use it in cases that I feel are going to bleed a lot or are very vascular, like the one you're seeing here. Preoperative PRP, if possible, helps too. And controlling the blood pressure of the patient during the surgery. Oftentimes, these patients are very uncontrolled and they bleed a lot because their systemic blood pressure is high. I like using the smallest gauge possible. I think they bleed less. Complete removal of the hyaloid is key. Valved cannulas are very helpful, and controlling, bleeding sites during the surgery is very important. And this is really my preferred technique. I call it lift and shave. So what I do is I alternate between suction with aspirating the tissue and removing it. And lifting it a little bit from the retina. And once, I have a space, then I continue cutting. So I'm constantly shifting between aspirating and cutting with the pedal. And I think this allows for very efficient and safe removal of tissue. Here is another example. It's 27 gauge. I really like peeling tissue and membranes with the 27 gauge probe on aspiration, because it allows for very controlled aspiration. As you can see there, if there's areas where there is traction, the tissue falls back. So there's less chances that you're going to actually create an iatrogenic break or pull on the retina or create a macular hole when you use this versus forceps. After I remove that, then I really get under the tissue and peel everything else. Sometimes you get cases like this on the right where everything is plastered down and you don't really have an area in the periphery where to start your dissection. So what I do in these cases is I lift over the optic nerve. Usually fibrovascular tissue in diabetics starts along the arcades and in the optic nerve, and I lift it while raising the pressure. And there I have a potential space from which to start the dissection and removing tissue from the inside out. I call this inside out dissection, and I think it's very, very useful. Here I'm lifting the tissue a little bit with forceps, and once it's separated from the retina, I continue removing it. And these really hard cases, you're able to do them without necessarily, creating any iatrogenic breaks, which really decreases your prognosis. Other things that you can do, I like dissecting with the probe. I used to use a lot of here. The OCT is helpful. It can tell us what's happening in the fovea. I used to use a lot of viscodissection in the past, and this is just a variation of that. So here we see that the hyaloid is thick and it's partially attached in the posterior pole. So I get under it and I blunt dissect from side to side. And then once I create a space, I start cutting. So it is almost like doing viscodissection, but all with the vitrectomy probe. And the 27 gauge is small enough that it really lets you do that. Here I'm applying pressure on bleeders. I think pressure on a bleeder is a very good technique as you're doing this, because you don't have to, take your instruments out and bring another instrument in. I always laser really well the periphery. I think that's important in these cases also. So here, oftentimes, bleeding occurs after surgery because the sclerotomies did not close well. So there's several techniques to that. Not only does using 27 gauge is helpful because it's a really small gauge, but sometimes they're still, intact. So what I showed here is you can either comb it at the end, like I'm doing there with an instrument. And if that doesn't work, then just putting the needle in the opposite direction that you went in can be helpful too. I do that with a 30 or a 27. Carlos Mateo has explained this really, really well. When you get post-op bleeding, one of the reasons why I really like using gas in these cases is that bleeding, which is the most common complication post-operatively, you can manage that by doing a fluid air exchange in the office, which I do all the time. It's a very simple procedure. Takes 2 minutes. I have timed it. And it allows you to clear the hemorrhage in, I would say, over 90% of the cases without having the patient to undergo another surgery. Another thing that's important is that some cases will redetach, particularly the traction and rhegmatogenous ones. So it is really, really important to determine the cause. It can be missed breaks. It can be, so I always mark breaks. If I create iatrogenic breaks or the patient has breaks, I always mark them with diathermy so I can see them better when I go under air. If there's residual traction left in traction and rhegmatogenous detachments. PVR, if it happens in diabetics, is usually because, as in this case, because of incomplete removal of the hyaloid. So that's an important point. And in cases that are monocular, if they redetach, I tend to use silicone oil. And this is an interesting case. This case had surgery elsewhere about 3 times. This is the only eye of this patient. And here you can see that this patient failed because the hyaloid was still attached. And you can see all of these breaks in the periphery. It still had this massive fibrovascular tissue. And here I'm doing a lot of scleral depression because there was a lot of traction towards the periphery. Superiorly, I'm injecting perfluorocarbon liquid, which I don't tend to use so much in diabetics, but if you see this case, most of the pathology was peripheral. And that actually helped me flatten everything without having to create posterior breaks to do a retinectomy. And this case, even though it was a one-eye patient, I actually left gas. I left SF6. I told the patient, look, you're not going to see for about a week. But I think you're going to do much better with gas. And he actually did, and he has remained attached in that eye. Some cases actually progress from a traction detachment to a traction and rhegmatogenous very, very fast, which is why I have been an advocate of early vitrectomy. And this case exemplifies that. This case comes in like that, has a traction detachment, more photocoagulation was added. But then in a span of less than a month, converted into a traction and rhegmatogenous. And here these cases are harder to do because the retina is much more mobile. But what I'm doing is most of the traction was circumferential along the arcade. So I'm segmenting all of those membranes there. I have already removed the peripheral vitreous. So I am really here, what I'm doing is cutting all of the attachments along the optic nerve, segmenting all that. And here I'm blunt dissecting. Even though the retina is detached, I'm getting under the membranes in the same fashion as I would have done with viscodissection and lifting that tissue. Here you can see that I marked this break with diathermy, and I am aspirating through there, and this is the view, afterwards. And some cases are really, really bad, and you think you will not be able to attach them. And this is this case, 35-year-old, type 1 diabetic, and Mosion's vision. But I think I agree with Natty, you should really try, because sometimes the cases that you think, are inoperable, you get some really pleasant surprises. And this case was one of them. I actually knew this patient. He worked in my building, and I really worked at it with 27 gauge, and 4 years post-op, he has still remained 20/70 vision. So they can do pretty well. And I think this case really exemplifies a lot of the techniques and why I think 27 gauge is so useful. This is 27 gauge with the 20,000 cuts per minute, which is the new technology. It allows you to use 27 gauge as efficiently as 25. You can see how quickly it is removing the peripheral vitreous there. I always use vacuum at the highest and control it with my pedal. And you can see how this case actually went very quickly. You can see the timer there. It's 23 minutes so far. So here I'm doing this. I like, lifting the tissue a little bit. And then when I have a space, I start cutting. I'm aspirating the blood. And here I'm getting under the membranes and cutting the epicenters in the same fashion that I would have done if I were using scissors. So here I lift a little. When I see some resistance, I see the epicenter, then I get under. So basically, this is like doing bimanual surgery with one hand, because the probe serves as scissors, as forceps. Here I'm using it as forceps, lifting the tissue. And then when I cut, and then when I see an epicenter, I get under it and cut as if it were scissors. So here I'm doing the same thing. I'm lifting the tissue a little bit, getting under it, and then cutting the little spaces and then shaving it. And this case, as you can see, we have been operating this eye for 32 minutes only. So these cases actually go very quickly. You can really shave the abnormal tissue from the surface very, very safely with this 27 gauge probe. This is at the end under air. And many times, if there's no breaks, I just leave air in these cases, and you can see how it did afterwards. And I'm just going to show you these two pictures. I think, I'm showing you how to manage all of these bad traction detachment cases, but I think the key is prevention. And of course, since most diabetics are not going to take care of their diabetes optimally, and we actually see them when they have advanced disease, I think the best prevention for all of these detachments is early vitrectomy. And I'll just show you this. This is a case that I saw like this. I started doing photocoagulation. I told the patient that he would need surgery. He was getting, all of his things in order because he had to take time from work. And in 3 weeks only, he progressed to this massive proliferation here. And this one was a case that I just did last week. As you can see, this picture on the right is from May 11th. This patient was seen like this on the left. Right before the COVID pandemia came in, he was scheduled for surgery, but we had to cancel it because we were only doing like extreme, emergencies. And in the span of just 8 weeks, he progressed from that picture on the left to this picture on the right, which of course it's way much harder to fix this than to fix this. So my message to you, the most important message today, is that early vitrectomy is the best prevention for traction detachments and severe traction and rheumatogenic. So when you see a case like this or a case with very advanced proliferative disease, I think we're doing the patient a service by doing early vitrectomy. I have never regretted doing early vitrectomy in an eye, but I have always regretted when I waited too much. So in conclusion, embrace new technology, think outside of the box, learn from others, go to the OR with a plan, but be ready to change your plan as unforeseen things happen. Be very meticulous, adapt to changing situations in the OR, and don't lose control of the eye. And above all, stay calm at all times. So I want to thank you. I hope this pandemic ends soon. Please, everyone out there, stay safe. We want to be able to see all of you very soon when all this is over. So thank you so much.
Thank you, Maria. That was wonderful. That was great. Hey, Maria, you show such wonderful cases all the time, and your technique is great. And I happen to be somewhat similar to you in the way I operate. It's funny that those of us that have been around long enough have gone through all of the phases of surgery, and when chandelier lighting came about in maybe the late 1990s, early 2000s, there was such a move towards bimanual surgery because that's what we had to do. And now with the evolution of instrumentation, I've shifted my surgery, much as you have, to operating much more with the cutter as a multifunctional instrument and using what is, I suppose, considered more unimanual surgery. I think particularly those are the techniques that one should learn now going forward. Although I do think we all need to be able to do surgery with bimanual technique. Tell me about your experience and how often do you find using a bimanual technique with a chandelier?
Well, I still use my manual technique. I think you need to. Sometimes the tissues are just so adherent that you cannot get even the 27 to create a tissue plane. This is particularly the case when you have a lot of peripheral pathology because the peripheral retina is much thinner. So oftentimes you cannot lift it. It gets plastered more if you're doing sickle cell cases. And I then use bimanual techniques. So I think it's important to just be comfortable with all of the techniques and use what works for you in different cases. If the tissue starts peeling easy, you don't need bimanual techniques. If it doesn't, but I really like the chandelier in the case that, I usually operate without an assistant. So I can do everything myself. I can sterilely press myself. And it gives you a much better view. And I really like using 3D systems of visualization. I think that has been optimal. And now that we have the COVID, it is so much easier to operate that way. The oculars don't fog so much and you're much more comfortable and you see a lot better.
Maria,
So I think, yeah, go ahead, Robert.
I love your technique. Just want to ask you, what your tips if you have some bleeding? I noticed that you just push the tip underneath the bleeding. It's good technique. What
Yes,
is
well, I do different things. Like if the patient starts bleeding a lot, I first ask the anesthesiologist what his systemic blood pressure is, because oftentimes the anesthesiologist is doing other things, and not paying attention to that. So I make sure that the blood pressure during the surgery is controlled. Then I raise the pressure of the machine. So if it's bleeding, I usually go to 50 or 60. But if it's still bleeding at 60, I may go up to 80 for a short period of time so I can clear the blood and see where the bleeders are. But if the bleeders are in the optic nerve, right, you're not going to do diathermy on those. So I usually press on them with a vitreous cutter because years ago, Klaus Eckert had a little instrument called a Heem stopper, which was like a ball that was in 20 gauge to press on vessels on the optic nerve when you had bleeding. So I just do the same thing. And in that video, I was just showing pressing on the vessel a little bit while you raise the pressure. And oftentimes then you don't have to use that much diathermy because when you diathermize, a vessel, you always run into, the problem that you can actually obstruct it. So the pressing on the vessel works well too.
Fernando? Thank you, Maria.
So, Maria, as usual, beautiful videos, amazing surgery. You're definitely the queen of vitreoretinal surgery. I wanted to ask your opinion about the hybrid approach. I'd like to use, being an academic institution, a combination of 25 and 27 for these cases, or 23 and 27, with the idea that it can help the 27 to reach easily the periphery. But also, very importantly, I think that it helps me when I don't have all the 27 gauge instrumentation, because then I can use any 23 or 25 gauge instrumentation that may be available. As you know, in academics institutions, sometimes they don't have everything that we need on 27.
Yes, I don't use a hybrid approach, but I think that is a very reasonable thing, because that way you can use all your instruments, but you have the advantage of the really small cutter to do the very, delicate work. Something else that you can do, I think now that we're going to have the 20,000 cuts per minute, that really, it's a dual opening probe, so it is open almost all the time. So it actually removes tissue as efficiently as 25. So a lot of people were not using 27 because they thought it was much slower to remove vitreous. So that will, preclude that. Oftentimes, what you can always do, if you have you can do a case 27, which will actually save money to the institution. You can do everything 27, and then you can save some 25 trocars. And in your dominant hand, you can put a 25 gauge trocar there, or ask, for trocars, and put a 25 gauge trocar, a 23 gauge trocar, and then use, your scissors or whatever case. And that way you may not need to open two packs or open two probes. I'm just telling you some for the world audience, some ways you can save money. Cases.
So Maria, so I have a quick question for you. Sorry, Georgie. So
Okay.
Maria, so we all know that even the Europeans are doing that very often these days. So all these eyes, sometimes they are so complex and they are very inflamed eyes. My question is twofold. First, though, do you consider steroids in the end of these cases, or any experience with Ozurdex, or even with Steve Charles, thinking about leaving some perfluorocarbon liquids in some situations too? What are your thoughts on that?
Okay. Well, I do use steroids, not on these more cases with detachments, but if I'm doing, let's say, a case that has severe macular edema in a diabetic, I leave triamcinolone at the end of the case intravitreally. You can also put triamcinolone subtenons, and that helps too. I have not used. I have actually put an Ozurdex at the end of the case, but for macular edema, not for these traction retinal detachments. Because in the traction retinal detachments, what I like doing is usually removing everything and then leaving air. I always leave air, and I position them one day, because whatever folds they had in the back, I think it helps flatten those quicker. So I just position them with air one day. I do not like leaving perfluorocarbon liquid in the eye in diabetics in particular, because what happens is that, they're always going to bleed a little bit. So in the clots, you're going to get droplets of perfluorocarbon liquid, and you have to do another surgery to remove it. So, I really think you should I'm a simplifier. I like doing, as you can see from my videos, I like using the least things that I can. I want to accomplish, I go with a mission in my mind, and I want to accomplish it as quickly and as seamlessly as possible. And if I can avoid another surgery to the patient, I think that is a huge plus, in so many ways. So that's why I like gases better. I think they tamponade. They have a tamponading force which is several times greater than silicone oil. So they actually press on the retina better. You don't get perisilicone proliferation in those cases. And if they rebleed, it stays in the fluid, and you can do a fluid air exchange in the office and avoid them, more surgery. So that is really my thought process.
Maria, I have some questions from the audience. A friend from Brazil, Plasco Bravo, asked, you said that you keep up to 60 to 80 pressure for bleeding. And how long is it safe to keep this pressure so high?
Well, I think you should leave it as short a time as possible. But you have to think that if you put it at 60 and the central retinal artery is still pulsating, you still have flow into the eye. So, because it really depends on the patient's systemic pressure. So that's why I always, tell the anesthesiologist to be very keen on what the pressure is. But I leave it for as little time as possible. So, if I'm cutting a lot of vascular things, I may raise it to 60. And once I finish all that, I look at where the bleeders are. I may diathermize them, I may laser them, or I may press on them. And then as soon as, usually when you use the pressing technique, in 30 seconds, usually, the bleeders resolve.
Okay, thanks. I think Carlos want to ask you some questions, some comments. Carlos, are you there?
Okay, Maria, can you hear me?
Yes. Hola,
Okay, my question is, in some of these cases with traction retinal detachment, some of them after the surgery they have fluid under the macula, and do you perform posterior or in mid-peripheral retinotomies to remove part of this so dense fluid that may stay in the macular area for months, even 1 year, in cases that you don't have any break, but this viscous fluid stays in the macular area, preventing improvement.
Yes, that I have seen that, but I usually do not like doing posterior retinotomies. But what I do in those cases is I may leave a longer acting gas. So instead of leaving air, which I do if there's no breaks, I normally leave air. But in cases like that where there's a lot of fluid or there's like a lot of traction, I may leave SF6 or C2F6 and position the patients maybe for a week or so, or 3 or 4 days, a little longer. And I think that can be helpful.
Very nice. I love your talk, but I think we have to move on. I think now have to ask my friend Dave Chow from Canada to share with us his talk. Thank you, Maria, so much for helping us.
Hey, everybody. Can you hear me?
Very good.
Perfect.
Loud and clear.
All right, here we go. Let's get these slides going. Everybody see that? You see the screen?
Yes.
All right.
Perfect.
Very clear.
Perfect.
All right, excellent. So what I thought I'd do, I think Retina World Congress asked me to present some surgical technique here and to do it ideally in 4 or 5 minutes here. So I'm going to give a little bit of an update in my evolution of management of optic pit detachments. And, at the present point, there are an awful lot of choices in terms of how we can manage this. And usually when there's a ton of choices, it means we don't exactly know the optimal choices. And you can see through the years, way back when, a lot of people were advocating removal of the highlight was about the only thing in common with all the procedures. The addition of peripapillary laser was in favor probably a decade ago, and it's really fallen off over the last decade. The value of a long-term tamponade and optic pit detachments has really kind of, again, been questioned over the last decade. ILM removal is pretty popular for many, but it does have a risk of creating a macular hole. Draining the fluid, will that allow quicker recovery? And if you're going to drain, do you drain through the pit or do you create a retinotomy? Rick Spade has discussed the newer technique, or interretinal fenestration to redirect flow of fluid. Radial optic neuropathy, macular scleral buckles, these are all things that have been tried in addition. And I guess the more recent era, like our macular holes, the optic pits, people have started plugging the pit with all kinds of tissue. This is a series of 3 patients from Dr. Travassos using a piece of sclera that's been harvested from the infranasal quadrant and then plugged into the pit. And then ILM flap is another one. You can either create a flap. The problems with the flaps, they can unfold, or you can take a free piece of ILM and plug that into the pit, but then it can displace and disappear on you. So way back, I guess 2007, when Khaled Sabti was one of my fellows, we had an index case of a 30-year-old woman with an optic pit detachment where we did what we thought at the time was pretty standard surgery: remove the hyaloid, remove the ILM, put a little peripapillary laser and a gas bubble. And she did well for a while, but she redetached, 1-2 months post-operatively. And it was at this point that we were right next door to the neurosurgeons. We're closing a CSF leak with Tacil. And we were kind of talking about it. And then Khaled looked at me and says, "Hey, what do you think? Should we try Tacil for an optic pit detachment?" And that was kind of our index case of using a tissue fibrin sealant. And then from that index case, we ended up going on to use it in many optic pits, and also extended the boundaries. And in this video here, I'll just show you, this is after we've kind of completed the vitrectomy and performed a meticulous air fluid exchange. What you see me do there is drip the Tacil onto the retina, and over time you can see it polymerizes here, forming this kind of fibrin sheet covering the entire posterior pole. And so that was always a very dramatic surgery. The fellows loved it. It was like kind of one of those jaw-dropping things for the fellows who weren't seeing that type of thing and anything else. And then here you can see, we had, in the publication, the series of failed macular hole, staphylomatous RDs. We used it for retinotomies. We used it for macerated non-sealing sclerotomies. And over the years, everybody kind of asked me, well, how long does the Tacil last there? And so you can see there roughly by about 1 week that the Tacil is already dissolving. By 2 weeks, it's usually pretty much gone. The more recent evolution is we switched from Tacil to Evisil about 3 years ago. And here you can see a series of 4 patients we published using Evisil to replace Tacil. And I'll speed through the video here and then show you again, as you drip the Evisil onto the retina, it eventually polymerizes and forms a nice solid sheet of fibrin there for you. All the same sequence of steps up until the point of using Evisil instead of Tacil. And why Evisil? Why has that become more popular? Because it forms a stronger fibrin clot, it forms quicker, it's resistant to stretching, and it does not contain bovine aprotein. But like Tacil, it is a pooled blood product which comes with those associated risks. Others have played around with the addition of some type of fibrin concept, such as autologous fibrin or platelet-rich plasma. So where am I now? This is my most recent kind of evolution in optic pit detachments, is essentially using Evisil, but then incorporating the ILM flap. So here you can see in this particular case, a very tight hyaloid, an unusually tight hyaloid, I would say. Historically, I've done a lot of optic pits, and not usually this tight. You can see the retina almost trying to detach as we're pulling this hyaloid off. And once we've got the vitreous removed, now we've stained with ICG, and this is a finesse loop, which for me has largely replaced the Tanno diamond membrane scraper for everything I used to use that for. And then I'm kind of creating this, disc-based flap, which then I'm going to essentially fold the flap into the optic pit and kind of stuff the flap in there and do an air fluid exchange. I don't do laser anymore, so that's kind of disappeared from my list of techniques with optic pits. And this is the Evisil being dripped on. You can see how quickly that polymerized. It formed a kind of a little bead of fibrin that I had to remove off of the cannula there. And then I, centered it, placed it before it totally polymerized and stuck down. And so that's really now my current management for optic pit detachments. So I'll stop presenting and then let you guys add your thoughts on optic pits.
So, David, this is beautiful techniques. I published years back a series with my fellows at the time at King Khaled, a specialist hospital in Saudi Arabia, Abu Mo and Soleiman And we looked at cases comparing, and I think the key here is having a control group. And we compared the technique of vitrectomy, detaching the posterior hyaloid, and laser in the peripapillary area versus no laser. We also look at ILM peeling and the use of gas versus no gas. And what we found is that detaching the posterior hyaloid with and without laser had the same results. Peeling the ILM didn't make a difference, and leaving gas didn't make a difference. So it seems that the simple technique of just vitrectomy, detaching the posterior hyaloid, is what works for these cases. And the key is that following these cases over time, the fluid will reabsorb very slowly. In our series, it takes about a year for the fluid to go away completely. It is successful in more than almost 90% of the cases, no matter what you do, as long as you do a vitrectomy and peel the posterior hyaloid. So I think that adding those adjuvants like a scleral plug or ILM or tissue or T-seal or any glue has to be compared in a series. Very beautiful videos and options, but it has to be compared in a series with the more simple technique to see if there is a difference. But I commend you on beautiful technique that again needs to be proven on a comparative series.
Yeah, fair enough, Fernando. I think, through the years, I've often been asked to use this routinely, the Silva, and I do. And you're right. We haven't. The problem with optic pits is you're going to have a very large multi-center trial to have enough volume of pits to do exactly what you're suggesting, right? And so, if anybody had enough energy to organize that and make that feasible, you're absolutely correct. I think what happened is because of the initial experience I had with Tacil, I ended up getting an awful lot of re-op. And so I know a lot of people have said, oh, well, I do the optic pit and it works pretty good. It takes a long time for the fluid to resorb. The success rate's pretty good. What I've noticed from my own experience is a lot of those optic pits redetach later on. And I guess I got a little bit of a biased opinion because of that experience after Tacil. When I presented at the Vitreous Society, I was getting all kinds of secondary redetachments with optic pits referred to me from all over the place. So I got this kind of disproportionate experience with all these secondary optic pit detachments redetaching. And in that series of patients, there's no question to me the addition of the fibrin sealant made a lot of sense because it was a second surgery, not a first surgery. But you're correct. For a first surgery, it would be ideal to have a randomized trial. But there's so many variants and options on what to play around with there. It's hard to answer all the questions easily.
David, this is
Yeah.
Tarek. I think what Fernando said is correct about it taking a long time for the fluid to resorb in some of these cases. Do you find that possibly using glues or obstructive things put in or around the pit might shorten that time to resolution of fluid? Has that been your experience, that you could get it to flatten out faster if you use something like a glue?
Yeah, hard to know again. I think Fernando's correct. It's a lot of this is observational, and until you do kind of a comparative. The other thing is I typically do try and drain these pits. And so I do drain through the pit. And I know over the years, some people said, oh, well, the fluid doesn't come out through the pit. But at the end of the day, I would say probably in 60% of the pit cases I've done, maybe 2/3, that when I put, and try and drain through the put, you can see an aggressive fluid coming up into your soft tip cannula. So I think the fluid can be drained out through the pit. So, you could argue, is that the variable that may lead to quicker resolution of the fluid or not? And so you'd have to look at that. You'd have to look at the addition of a sealant. You'd have to look and see whether you'd put an ILM flap in there. There'd be so many ways if you were looking at a publication or a submission for publication on this, the editors could pick it apart in 3, 4, 5 different ways in terms of the science.
David.
So David, I'm sorry, just a quick question here. Well, David, you know that we've been struggling with the optic nerve pits for like decades, and you mentioned that, and Fernando too, because we only have a small case series, so we all have our doubts on how to manage that. But I think that we reached a point where at least we should try not to use destructive techniques like the laser, like Fernando said, because we've been using a similar approach, like peeling the ILM and just placing the ILM like as a plug. And then in the end of the case, we use some viscoelastic, dispersive, viscoelastic, just to keep the tissue in place, because that they can move away very, very easily. But I think we'll never reach the point where we can get like a multi-center, because there's always like small case series, and we're always gonna have our doubts on what technique to use. But what do you guys think about stopping using laser? Because we all know that if you place the laser, that we know that we are not damaging anything, and at least we believe in that. But if it fails, at least we have some other options in the future, as you mentioned, because some of the cases they don't evolve well, you have to go back in there. What are your thoughts on it?
Yeah, I think the downside of laser is to really seal properly. You have to have a full thickness retinal burr, right? So because of the nature of what we see on an OCT with some of these schisis types of formations, and where exactly is the flow of fluid occurring from the pit into the retina, and where is the source of leakage, and what are the pathways of that leakage, to really have confidence in a laser, you got to create a full thickness burr, which is not something we really want to be doing, ideally in a peripapillary location for 180 degrees, right, or more, right? So I think there's where, I think I totally agree with Fernando. I think, and his, as he said, his series showed no advantage to adding laser. So in which case, then why would you add the laser when it does have a destructive component? So I agree with that. Doing soft laser makes not a lot of sense to me.
Beautiful case, David. I think Ahab has some comments. Ahab, please turn on your phone.
Can you hear me now?
Yes.
Well, my comment actually was following Tarek's comments about the fluid. Why doesn't it go away? We have to understand that the fluid in most of these patients are not just subretinal, but sometimes they're intraretinal or sub-ILM. Other than the nature of the fluid, we think there is also some type of CSF contamination which brings the viscosity of this fluid. So there's several factors why we follow up these fluids for quite some time and they just don't go away. It's not just vitreous fluid. Might be coming contamination with CSF, which increases viscosity, and where it's trapped, intraretinally, subretinally, or sub-ILM. So again, the cure of optic pit has to be focused on closing the source and removing the fluid. So as we see from all what David said, even he has to add by removing the fluid by trying to drain it, but where to drain, intraretinally or subretinally. That depends on the OCT. If we can get it pre-op, it guides us to maybe when we need to drain, or these patients will take longer time to absorb, or how we add our surgical options. The one more point I just wanted to figure out is when we do ILM peeling, we're not removing or increasing retinal elasticity. And we must keep in mind that we might deroof cysts or schisis that has to be there. So if I need an ILM to plug a pit, I would take it away from the fovea, not over the fovea, to decrease the risk of damaging the fovea or deroofing the cyst if there was schisis. I usually take it around the arcades to the optic pit. So I don't like taking it off the foveal area. So I know that there's a lot of ideas also for doing plugging.
Very good. I have a question from the audience for David, from our friend Fabio Patelli from Italy. He asks, when do you plug the pits? You plug all the pits, and when?
Yeah, I plug all of them now. I mean, in the sense with the flap, and so I would say that is my primary edge. I mean, I guess again, I have a disproportionate experience, as I said. So I do think now for my primary surgery, I will create the ILM flap and then kind of fold that into the pit and stuff the pit with that. And then, the Evusil I showed you is something that occurred as a primary experience of having a whole lot of reops. I totally understand why a lot of you are going to look at that and say, I don't really need to do that on my primary surgeries. And I'm not going to argue with that at all. I think the only other argument you can make for the fibrant sealant on a primary case is if you look at the literature on wound healing, it turns that when you have burns and things like that, and they use these fibrant sealants externally, it forms a wonderful scaffold for wound healing to occur across. And I've never been able to prove this because our imaging isn't strong enough to do so. But I guess one of my hopes is that fibrant sealant covering the pit may allow a scaffold of tissue to kind of cover that pit over, like you would burns on the skin, and that may also aid in these closure of pits long term as well. But I can't prove that. I wasn't able to do that with our OCT imaging. It's hard enough to find the pits on OCTs, never mind show what I just hinted at.
Very nice, David. I love the discuss peak, but we have a bunch of good things, and we need to move ahead. And now we can ask my friend Miguel from this Uruguayan Association of Digital Retina. We're gonna talk about tips from diabetic vitrectomy. Please, Miguel.
Thank you, Jorge. Let's see if it works okay.
Yes, I can hear you very well.
Okay. So, thank you very much for the invitation. I want to thank the World Retina Congress, especially Dr. Tarek Hassan and Jorge Rocha for this opportunity. It is an honor for me to participate in this webinar with such prestigious colleagues from all over the world. Very difficult to talk after Maria, but I will try it. I will repeat some concepts, but I think it will be okay. In this presentation, I want to explain how to approach to PDR in 5 steps. Of course, all patients are different, but the scheme can be applied to practically all of them. And I think it may be important to people who are starting to do this kind of surgery. To start, we always want to peel everything: membranes, fibrosis, PVR, ILM, etc. But can we do it anywhere? Generally not. In this patient, we can't detach the hyaloid as we usually do, because, as you know, we can find large areas of high adherence. But you look at the fundus between the vascular arcade, this is the area where we can do it, where we can be able to peel more easily. However, when you move away from the macula, we will prefer to detach and cut, as Maria says. What can we do? What are the best instruments for each step? To peel, we will use forceps. To detach, we can use both forceps and the cutter aspiration mode. To cut, we will mainly use the cutter. We can also use scissors for some maneuvers. Nowadays, the bevel cutter, small gauge, high-speed cutting, these 2 maneuvers are more easily done with the same instruments. Dr. Berrocal have shown us many videos about that. We do not forget the fundamental weapon, that is the anti-VEGF before the surgery in this patient to reduce the chances of bleeding during the surgery. The first step, we should always remove as possible the anterior hyaloid. This is very simple in the pseudophakic patient. However, it's a risky maneuver in phakic patient where we can touch the lens. Why is it so important to remove the anterior hyaloid? This patient rebleed frequently, and the anterior hyaloid is easily impregnated with blood and often even with small bleeds. Usually, this impregnation persists over the time and lowers the patient vision and does not allow us to see the fundus. In pseudophakic patients, we always take advantage of a posterior capsulotomy for the same reason. In this video, we show how to remove the posterior hyaloid behind the lens. As you see, we don't need the use of the biome to do it. The red arrows will indicate the limit of the remaining anterior hyaloid. In this other video, we show that we should not be obsessive with the removal of the anterior hyaloid in phakic patients. It is enough to generate a posterior window to the lens, since we can injure the lens as we show in this video. Once we injure the lens, we must necessarily remove it. It will opacificate for sure. It can also cause a large inflammation if the posterior capsule is broken. Second step, the circumcision of the hyaloid. This is the cut of the hyaloid 360 degrees at the equator. This will prevent to create peripheral iatrogenic tears during the membrane extraction as the posterior pole. Finally, you must try to remove all the peripheral hyaloids. In this video, we show how we do the circumcision under triamcinolone staining. The red arrows will indicate the limit of the circumcision. In the third step, we must detach and cut the hyaloid. The red arrows indicate the places where we can do it, and the crosses indicate the areas of high adherence where we cannot pull, since otherwise we will cause iatrogenic holes. In this technique that we know as segmentation. This technique aimed to release the traction on the retina. In this other video, we show the technique of detach and cut only with the cutter. We must alternate aspiration mode and cutting mode to make it possible. We show how the areas with low adherence are detached and the neovascular outbreaks are segmented. Then they are cauterized to avoid bleeding. We must be very careful. You don't have to do it too much traction to the neovascular outbreaks. Finally, in this patient, we perform a palm photocoagulation and a peeling of the ILM. Of course, these surgeries are long surgeries, and we must be very patient. We leave it under air. In this video, we show a patient with a more severe PDR. We are going to combine manual techniques, the cutter, as you see. Then we will use some forceps, and finally, a bimanual technique under chandelier to complete as much as possible the dissection of the fibrous membrane. The extraction of this membrane is not easy, and there is always a risk of generating iatrogenic holes. We must be very careful in the plane of we put the scissors. We put some PFCL to stabilize the eye, and then we will do a retinotomy to drain the subretinal fluid. In this way, the retina is attached. Finally, we make some laser under PFCL and a silicone oil air exchange due to the severe case. If not, we prefer gas, as says Maria. The step 4 is the peeling of the epiretinal membranes and ILM at the posterior pole. In this way, we will be treating all the tractional elements that involve the macula as well as the macular edema. We can not do it every time. It will depend on the severity of the case. In this video, we are showing the ILM peeling under a brilliant blue staining. This patient has a significant amount of hard exudate that surely shows a very poor metabolic control. The last step is to perform a complete pan-photocoagulation. Perhaps would prefer to leave the patient under anti-VEGF. However, in our opinion, we always should do it. In Uruguay, many times, the availability to this medication is not so easy. We never know when the patient will bleed again. That's why, for me, it's so important to do it. We must reach the periphery because there is often a lot of ischemia in this area. If necessary, we can make indentation to do it better. Remember that many of these patients have a poor dilatation. To summarize, we believe that this PVR treatment scheme is important for those who are starting doing this type of surgery, which we believe are among the most complex vitrectomy cases. We disagree when fellows are told to start a vitrectomy with a vitreous hemorrhage in a diabetic patient, as if this surgery was the simplest. We never know what may appear behind a vitreous hemorrhage. Remember that. And don't forget to inject anti-VEGF before the surgery if it's possible. So, thank you very much.
Thank you, Miguel. That was terrific. Great tips and presented in a beautifully ordered fashion for us to, understand your thought process. Would you comment for us? Would you comment for us, Miguel, about where it gets particularly difficult and maybe your approach to the hardest of these types of cases when there's a regmatogenous component to the detachment? For example, do you try to isolate the holes or the tears first? Do you approach the peeling of this area first and then go towards the rest of it? Or do you try to peel the rest of it and go towards the break? Those sorts of approaches. Once you add that regmatogenous component, I think we would all agree that the level required of intensity and skill and fear that is engendered goes up a little bit.
Yes, I think it's important to do the circumcisions always, if you can, because that will prevent, if you already have some tears, you don't want to have more. So if you do the circumcision, you are avoiding to do, I think, more tears in the periphery. I think you must isolate the tear and do the circumcision, and then you can put some PFCL, but that you put PFCL after you take off the hyaloid, because if you put PFCL and you do not remove the hyaloid will remain, and it is a problem after that, as Maria showed.
I have a comment. This was Miguel, this was a wonderful, wonderful talk. And I think you pointed out the most essential things here. I think I really liked your main points, that using triamcinolone is very useful, especially when you're starting out. And oftentimes when you can't see, and I think liquefying the triamcinolone like you did
Yes.
diluting it is very important because then you can see better. The other tips that I liked were doing PRP. I think the mistake that many people do is thinking that because we have anti-VEGFs, we don't need PRP.
Yeah.
And when we think that in the US, 25, Mike Singer wrote this paper that 25% of patients that have appointments for anti-VEGFs miss the appointments. And we know that if somebody does not have PRP, a diabetic, and they have been treated with anti-VEGF and they don't come in, like Mark Johnson showed in another paper, they can come in with neovascular glaucoma and we can lose a lot of these eyes. So I think that it's really, really important for everybody listening that PRP has not gone away. We still need PRP, particularly in these really, really hard cases. I don't peel ILM in all of the cases, but I think if the ILM looks very thick and is causing stria, it should be peeled. And the comment that I wanted to make is that the OCT is really useful in these cases beforehand, or if you have it intraoperatively, even better. But beforehand, because some of these cases may have large cysts, and in those cases, when I peel the ILM, I leave it. I don't peel it completely. I basically leave it attached in the area of the cyst because I don't want to create an iatrogenic macular hole.
Yes.
But this was a wonderful, wonderful talk. I really, really enjoyed it, and I think you covered everything beautifully.
Thank you, Maria.
I think it was a beautiful talk, Miguel. I just want to make a comment about perfluorocarbon. I mean, you presented so many things that are beautiful and that I would like to comment, but on perfluorocarbon specifically, I describe a technique called perfluorodissection. So sometimes you can inject perfluorocarbon between the posterior hyaloid and the retina and help that way perfluorodissect up to the periphery in some cases. It's part of the armamentarium. It really depends on how the retina and the other adhesions are on the tractional retinal detachment. It's not something for all the cases. If the retinal adhesions are very strong, I don't continue injecting. If they continue separating, I continue injecting. So it really depends. Now, I also use it when I have peeled all the membranes. And then, as you know, when you have a complex case and you peel all the membranes from the retina is very edematous after being detached for a while. So using perfluorocarbon helps you first control the places where there's hemorrhage, and you have to perform less endothermy. And you can also perform better endolaser with the use of perfluorocarbon. And if you're going to do a retinotomy, it's better to use perfluorocarbon and displace the fluid peripherally and do a retinotomy in the periphery. So perfluorocarbon has its uses, but you have to be very careful because it can go under the retina if you don't peel out the traction. So you have to be careful. Yeah.
Yes, of course, I agree.
Very quick, Miguel. Just here, I would like to make a point here. Beautiful presentation, beautiful cases, but one thing that we've been neglecting for and not doing for decades, and I don't know why, since we've been using wide-angle viewing systems. But I think chandelier lights, they're like a must, and we learned a lot from the use of chandelier lights. And as you mentioned, and Maria also mentioned, that we should apply PRP, even though these days at the mid-periphery, we are not being very aggressive with PRP because we do have anti-VEGF, but you showed quite well that we should be more aggressive at the periphery. That's why doing your scleral depression is so very important. And I don't know why we never did that in the past, but we are doing now because we know that we all used to have those rebleeding cases because we didn't apply a lot of lasers all the way up to the to the ora serrata. But now, since we are doing that, we are seeing less and less of the rebleeding cases and also less neovascular glaucoma. That's why I think it is so important. If I had to choose one step of your presentation, I would emphasize step number 5. Beautifully done.
Thank you. Yes, I'm very afraid about the neovascular glaucoma. It's It's
Yeah,
very
so
common
I agree.
in
I
this
think
kind of patient.
I just want to reinforce that you're doing laser and also pre-op anti-VEGF. I think reduces the recurrent hemorrhage and also the hemostopper, which told by Maria in the previous. I think a wonderful learning, excellent cases.
That's real good. Miguel, I love your presentation. Very didactic. You can learn a lot, and emphasize that the step number 5. That's something that I learned. And sometimes I inject anti-VEGF at the end too.
Yes, I do that too.
Yeah, that's
Every
helped
time.
a lot. That's
Every
helped
time.
a lot. And
Yeah.
you know, very good talk. I love it. Thank you very much to share with us and help us. But now I need to move on and let our friend from Spain, Carlos Mateo,
Sure.
to speak too. Thank you very much. I
Thank
love
you.
Carlos, please.
Okay,
Carry on.
thank you. Let me try to share this. Okay. Okay. Do you see now? Do you see the screen?
No.
Not yet.
See you.
Yet.
We see you, Carlos.
See
The
me?
screen, not yet.
Okay, let me try again.
No screen.
The key. Okay.
I
Now?
see you, Carlos.
You see me now? You see the screen?
Yes, I do. It's coming.
The screen's coming. It's perfect. You can move on.
Okay. Let me tell you, Tarek, Hassan, Jorge, Fernando, and Andre, it is a great pleasure to be here. Thank you very much. My topic will cover something very important when you have traction and recommendation of retinal detachment in patients with PDR. You know, and you mentioned before how important is in traction retinal detachments to remove the posterior hyaloid, but it's more important and more difficult when you have, you know, tractional and recommendation retinal detachment in these cases, because when you pull the posterior hyaloid in traction retinal detachment, the retina tends to be stable down because the RPE and all of this stuff. But you know, in recommendation retinal detachment, you're pulling both. You're pulling, you know, both the posterior hyaloid, you can see here, and the retina. This is the mechanism you are using to trying to remove the posterior hyaloid. Then, you know, with this you can enlarge. Then the thing I use is, you know, visco delamination. In this case, you can see the break there. And then I go under the posterior hyaloid, very soft. You know, you inject very, very, very slow, and you feel where are the strong additions between the retina and the new vessels. Then you do the same as Maria mentioned before, or Miguel. You cut with the vitreous tip. Again, we have here in the nasal side, have a very large contraction of the posterior hyaloid, and you have to remove this. It's not only, you know, to remove the new vessels. You have to remove the posterior hyaloid. Because if you don't do it, you can have reproliferation, etc. And of course, this.
Please.
Yeah.
Your video is not playing.
Oh, I'm seeing the video here.
Yeah, the video is not playing.
Let me try to do like this. You see now?
Now it's perfect. Thank you.
Okay. Let me enlarge a little bit. Okay. Then again, you know, I started here. Let me 1 moment, please. Well, I started here. And the difference is that I'm not trying to pull the posterior hyaloid. I'm separating, creating a space between the posterior hyaloid and the retina. The retina is pushed down and the posterior hyaloid is pushed up. Then you are not pulling both tissues to you. Then when you create a space, you can use your vitreous tip just to cut all of this tissue. You can see the break is there, the break of these fragmentations and recommendation retinal detachment. in this the nasal area, the posterior highlight is so attached that this is so difficult to remove only by traction. Then you are creating a space. Don't be rushed. Don't rush. You have to be slow, very gently, injecting, and then with a Vitamin tip, you can remove all of this tissue. Of course, this doesn't prevent the use of bimanual surgery. You have to use it in many occasions. Then in these cases, you can use silicone oil. Look at this case. Again, tracheotomy structural retinal detachment. As you can see here, when you try to pull the posterior hyaloid, everything comes to you and very easy to make breaks, and it's so difficult. Then I tried to find the way to enter in this space, and I began very softly. I began to inject this visco material. You can see the new vessels there, but I go around, and then the visco makes a detachment of the peripheral hyaloid. This is so important in these cases that you remove all the posterior hyaloid, because then you can have reproliferation and all of this stuff. And at the end, with the bimanual surgery or unimanual surgery, you can remove all of this tissue. You've mentioned the retinal photocoagulation. This is very important. This is the last case, very important case. As you can see, tabletop, very active, big break. Look at this. We cut the peripheral posterior hyaloid.
Carlos, it's not playing. It's not playing.
Not playing?
Not playing.
I'm so sorry.
For
The
me,
video.
it's playing.
I see it as well.
I can see it. I
I
can
don't
see it,
see it.
Maria.
Yeah, I see one too.
You see it?
Yep.
Yes,
Okay.
I've been able to see it.
Okay, then I'm injecting this viscoelastic material. Again, don't try to cut all of the attachment. The strong stocks is so difficult to break. Then you will need, of course, in these kind of cases, you will need, of course, to use bimanual surgery to clean all the tissue over the retina, all the tractions. But this helps a lot. This co-delamination helps a lot. In this case, I did a retinal transplant to close this, posterior break, laser photocoagulation. Perhaps you asked me this last case because there's only one eye, and at the end this patient had a difficult hand movement. Now it's 20/163. This is 1 month later. The problem here is when to remove the silicone oil. It will does the patient will maintain the same vision? I don't know, but I know visco delamination is very helpful in these cases with traction and rhegmatogenous retinal detachment. And that's all I wanted to show you. I'm so sorry. I could see it, very well in my screen. So sorry.
No, we could see a lot of it,
saw that.
Carlos. Yeah, we could see much of the surgeries. They were really quite brilliant. As always, Carlos, I love watching you operate. What is the instrument that you use to inject your visco?
In the beginning was named the Hubbard cannula. This is made of nitinol that you press and then becomes curved. 23 and 25. And this is very, very useful to change direction when you are injecting this viscoelastic material.
So, Carlos, these are very, very complex cases, and I think you did it beautifully. One of the things that we try to do, and we try to teach the fellows that is a key step to the surgery when you decide to go bimanually, is to have a good illumination inside the eye. If you don't go with the 3D, sometimes you need to use more than one chandelier light so you can see well and see where you're cutting. So how do you manage that as far as illumination?
I absolutely agree. Visualization is a key in our surgery. If you don't have good visualization, you will have a very bad surgery. In these cases, I only have one chandelier light, but if I need to, I don't have any problem. I put 2 lights to have the perfect illumination to do bimanual surgery or whatever I need to do. But even to remove the lens or whatever, you need to see perfect. If you don't see perfect, your work will be worse.
Excellent, Carlos. I enjoyed your visco dissection. And one thing I do sometimes is use the proportional mode of the vitrectomy so that you can make a cleavage between the the traction detachment and the membrane.
That's great. That's great. That's absolutely great. Absolutely great.
Carlos, these are beautiful videos that you showed, and I agree completely that in cases where we have a combined tractional and rhegmatogenous retinal detachment, a bimanual technique is very helpful. And I definitely see and like your technique of viscodissection to open the plane, and the reason of these very adherent membranes to need bimanual technique is because of that, because they are very adherent. But if you can open that plane, then you can use the cutter as well to help delaminate those membranes and use the bimanual technique to finish the case. Very beautiful technique as usual, Carlos.
Thank you, Fernando.
Carlos, I have a final question about the tamponade that you use.
Yeah.
The way I see, let me see your thoughts on it. The way I see silicone oil sometimes, not only as a tamponade, but also a hemostatic type of thing. Because if you have like an early recurrence on the bleeding, like, during the post-op, maybe if you have silicone oil inside the eye, so you're gonna actually make that blood clot more localized instead of having gas or no tamponade at all. So I see a silicone oil in some, of course, selected cases, not all of them, especially very complex cases like you beautifully shown, but also to contain the minor hemorrhages or maybe some major hemorrhages that you have during the post-op. What do you think about it?
Friend or foe, right? It helps you, or okay. I absolutely agree, but many of these cases are only one eye. Then you need the patient to increase, their vision. But again, if you put silicone oil, try to maintain the silicone oil as less as possible. One of the worst problems with silicone oil you mentioned is that you have a subsilicone hemorrhage in the macular area. And then the patient, the day after, you see a terrible hemorrhage just in front of the macula. The patient sees a terrible thing. Let me tell you the trick. The trick, if you have this, is to inject RTPA through the silicone oil. Put the patient, looking forward, and the blood will be down, will be disappear. It happened once to me that I operate a doctor, very bad case, similar to these cases, and the day after has a huge hemorrhage in front of the macula. And then I didn't know what to do. It was 10 years ago, and I said, I will wait. And again, when I went there again, was so difficult to remove this clot from the retina. Then my trick is inject RTPA once or twice, and the blood will disappear along from the macular area.
Carlos, very good. I love your videos. I have some questions from the audience. Our friend from Brazil, Nelson Sabrosa, asked, what kind of viscoelastico you use for dissection?
I use a Hilon 1% only. It has the advantage if it begins to bleed, it maintains bleeding around the Hilon. It doesn't flow. Then, I use Hilon 1%.
And another question for everyone here. What frequently we see neovascularization, I said, iris neovascularization after we fix a TRD and do PRP. How frequently you see this? I don't see very frequently. Usually nowadays I finish bad case with PGF and PRP. I don't see anymore. If someone can tell something, I think Maria, we're gonna comment.
Yeah, well, I see it very rarely. I used to see it more in the past. But whenever you see it, you have to suspect a peripheral detachment. I think this is a very important point, because oftentimes if you have done a lot of photocoagulation all the way to the periphery, you should not be seeing iris neovascularization unless the patient has some carotid obstruction or something else going on, or your laser was inadequate. So every time that you see that, inspect really well, do a lot of scleral depression, and inspect really well the periphery, because that can be the case. But I would say that I would see it less than once every 200 cases or something like that. But I'm very meticulous, just like Miguel and Carlos have mentioned about removing the hyaloid and doing a lot of laser. And sometimes if I think the eye is very angry or is going to like bleed a lot, I may inject anti-VEGF at the end of the case.
Absolutely. As you mentioned, as we decrease the number of postoperative retinal detachments from the breaks in the periphery that we had before, now with the Kenwell systems, we have less peripheral retinal detachments, and perhaps it's one reason why we decrease the numbers of iris neovascularization.
Miguel has some comments too. Miguel, turn on your phone.
Your phone
is off. Your phone is off. Just turn it off.
I think he asked the concentration of the TPA.
Yes, that's it. Sorry, that's it. The concentration of TPA and the amount of that.
To me, this is 12. It's 12 units per 1 email.
Okay, thank you.
George, regarding your point on neovascularization or rubeosis iridis, in India many times we get patients who are not lasered before, and they come with a traction detachment and one eye already lost with diabetes. In those eyes, we see neovascular glaucoma, and in the one eye, I actually have done, and then post vitrectomy with oil developed rubeosis. So I gave a intracameral anti-VEGF, and I took up for removal of oil and revitreous surgery and did more laser, and also added anti-VEGF on the table, and I think it did well. So I think we keep seeing, but not that often like before, but we see some patients who have not done laser, who not gone for any anti-VEGF, and those eyes we see rubeosis iridis.
Yeah, we see so many bad cases. We do this, and sometimes we can save with vision. But Carlos, thank you very much. I love your videos. It was marvelous. And I need to hear now our friend from Egypt.
Sure.
Thank you.
Hey, George, Carlos, all my dear friends around the world. Well, it seems like when George told me that I need to present a technique or a video related to diabetic vitrectomy, I was assuming that Maria, as well as Miguel and Carlos, were going to show us these great techniques, though as there was nothing more to add, speaking about techniques in diabetic vitrectomy. But maybe I was assuming that Maria will get the question about drugs, putting Ozurdex at the end, or putting any type of treatment that we do at the end of our surgeries. Well, this raises the point that definitely at the end of diabetic vitrectomies, we're thinking about either trying to prevent recurrence of macular edema, or improving macular edema, or preventing hemorrhage that would happen after. And in some situations, when we do a vitrectomy, you have a half-life of any drugs that we're going to put inside the eye, or if we put silicone, then whatever drug we're giving, anti-VEGFs usually don't have their sufficient effect. So I thought about focusing about drugs after vitrectomy. So let me share with you my presentation. It's a short video that I would think would help answer some of these questions. Putting drugs inside the eye is an important step. When you do it in a vitrectomized eye, you usually have a washout once you do the vitrectomy. Or if you put silicone, usually there is no diffusion of drugs when we put it, anti-VEGFs or others. So this is a catheter that we developed. It's a drug-delivered catheter that you can use at the end of your vitrectomy to deliver drugs, whether you're using anti-VEGFs or using steroids or any other treatment that will augment your effect at the end. It's a simple tube that is 250 microns. It has markings at the tip, so it's 5 millimeters apart, so you know how deep you are. And you can connect it to any type of injection to deliver whatever drug you want to put inside the eye. Even future drugs like we have in the pipeline that are more longer lasting, you have a way. So this is a patient that had an ILM peel for macular edema, and at the end, after finishing the ILM peel, I'm going to inject steroids. So we just make a conjunctival incision 4 millimeter behind the limbus, make a small incision there, and with the diathermy, I open the last bit of the sclera to expose the choroid. Then I use this catheter to deliver the drug. So you can imagine either you can deliver steroids, anti-VEGFs to prevent bleeding, rebleeding, especially if you're planning to put silicone inside the eye. You have the reservoir to put your drugs in that space there. This is connecting it to triamcinolone. You can inject up to 14 milligrams, which is much, much higher than what you inject intravitreally, and at the same time avoiding the complication of phakic eyes like having cataract or glaucoma when you inject it suprachoroidally. So this is the catheter, 5 millimeters apart. At the end of your vitrectomy, I just put a chandelier, so I have both hands free, and just slide this catheter right there all the way to the back part around the arcades to inject, for example, in this case, macular edema. If I stop the video there, there's the catheter. There is no light. Like the previous versions we used to do macular buckling with, this is a very simple catheter that you get from Med1. It's just the indentation effect. You can see it up here. You see that? Does anybody see it?
Yes, you see it. Perfect.
Okay.
Yeah, we can see it.
There's no light at the tip. It's just the indentation effect of the tip of the catheter. It's going to move. You'll see it moving now. There, I'm pushing it. It's here. Then at the target area, there's the tip right there. You can inject the amount of steroid. You'll see the wave that happens once you inject and the pulsation. There, this is the pulsation of the drug is delivered right here underneath the macula, and you can see the pulsation of the disc because the volume injected, we injected about 8 milligrams of triamcinolone right underneath the macula. You can ask how close we need to do it. Now we're pulling it out, and you just put one suture. So this could be done at the end of the vitrectomy if you're doing it for macular edema. And if you look closely to this slide there, that's the suprachoroidal drug delivered right here. It's underneath the upper arcade. So this is the baculation of the liquid, and at the same time, the triamcinolone, the particles delivered in the suprachoroidal space, causing this cavitation there in the suprachoroidal space below the arcade, right there. This lasts longer because it's in the suprachoroidal space. This is another patient with macular edema. Look at the amount of hard exudate this patient has. At the end of the vitrectomy, I was doing a vitrectomy here. I just put a chandelier so I have both hands free. And the same way, I just opened the sclera, expose the choroid, prime it with either anti-VEGF if you're seeing or you're predicting that there will be hemorrhages from a heavy neovascularization at the beginning of the case, or in case of a macular edema, it's just steroids. Expose the choroid there and gradually just dissect the choroid from the sclera by pushing a small viscoelastic bubble there to separate. Then again, use the catheter. It has an olive tip at the end, so it doesn't cause choroidal puncture while you're moving. Sometimes I put a chandelier or even just one chandelier at the one side. So I have both hands free, slide it inside the eye, gradually pushing against the sclera, not the choroid. Then once you're two markings, you start looking from the biome because you'll be around the arcade or at the equator. Then I start looking from the biome. So I have both hands free, just putting the chandelier there. Then you look inside, this is the tip right here. Then I'm going to extend it a little bit to around this arcade right here. You can see the indentation while it's moving. There's like a snake underneath the choroid. And in the targeted area, you can start injecting or delivering the drug. There, it's going to be injected right there. You see the wave there. And that's the site for the injection again. At the end of the case, this is a case that had lots of hard exudates and macular edema after doing the ILM peel. We'll look at the OCT before and after. And you can see the pulsation once you start delivering the drug inside the eye. So whatever drug you'll be using or what we'll have a little bit down the future, we have a reservoir to solve the problem of half-life or washout or even the use of silicone in these patients. And the same thing, the bubble was injected here. This is while doing an OCT. You can see it in the suprachoroidal space at day 2. And the macular edema before and the hard exudates here, and looking at the same patient again, 10 days later, the macular edema starts to improve and the hard exudates also have an effect from giving steroids in the suprachoroidal space. So this acts as a reservoir. It acts as a place that we might use to inject drugs inside the eye.
We have wonderful, wonderful talk. I think the applications of this are huge in the future, and I really love the use of triamcinolone for this. But I have a question for you. Have you seen increased intraocular pressure in the eyes that you have used triamcinolone? You know, given that about 25 or more % of the population is steroid responders.
Excellent question, Maria. Well, that's the idea behind it. When we were using triamcinolone before, we were using different concentration, all the way from 4 up to 12 milligrams. In the suprachoroidal space, we don't get the pressure spikes that we get for steroid responders compared to if you inject it intravitreally. Maybe one theory about it is the triamcinolone particles injected in the suprachoroidal space don't get to the trabecular meshwork. So there's definitely a big difference if you inject it in the suprachoroidal space and the effect of the pressure that happens. Not only the pressure, but also the length changes. As you saw, two of these patients were affected, and we didn't see significant changes in the length changes compared to just normal changes that happen from doing a vitrectomy. So definitely injecting in the suprachoroidal space, you avoid or decrease the potential complications of steroid on the lens as well as the intraocular pressure.
But we have sometimes some choroidal bleeding.
Choroidal bleeding did happen in the studies when we were doing this same technique to deliver viscoelastics for myopic macular holes or foveal schisis. But if you're dealing with normal thickness choroid, like an emmetropic eye or a patient with a diabetic, usually there is a very low incidence something this happen. There is a learning curve how to thread the catheter inside the eye. And at the same time, this catheter is so atraumatic because at the tip, it's like a tire or like a balloon. So it's dissecting the septa or the lamina fusca and dissecting it gradually, very slowly till you reach the target tissue. One thing is, do we really need to reach underneath the macula is another question. Maybe sometimes if you just inject it around the arcades or at the equator might be an option to decrease the path all the way to the macular area.
And when you inject some anti-VEGF, how much volume do you inject?
The same as you can inject inside the eye, but even now you have the option of increasing more because you're not afraid with that part. Except, of course, because you might consider systemic absorption for that, so I would inject the same concentration. The good thing about it, if you try to inject anti-VEGF in eye that you're planning, silicone oil is a hard time. And if you inject in a vitreotomized eye, there is a high incidence of washout and the half-life is very low. So I think that acts as a reservoir for slow drug delivery, whether you're going for steroids or anti-VEGF or any other drug we'll have a little bit down the road that we need to put inside the eye.
Thank you.
So, Ihab, I think you have shown a very beautiful technique. Thank you so much. I have injected drugs into the silicone oil bubble and it works. Remember, there is a meniscus of fluid and there is still effect of triamcinolone, anti-VEGF. Mateo Carlos just mentioned TPA. So it does work. However, what you're showing, it has significant advantages in terms of that the suprachoroidal space will decrease the chances of complications such as cataract and increase in intraocular pressure. My question is about durability. Do you have any idea of how long will triamcinolone last? 8 milligrams like you injected, for example, in the macula. How long will it last and how long will it take for something else to be injected in the eye for macular edema in diabetics, for example?
Excellent comments, Fernando. Well, we know from the pig model that triamcinolone in suprachoroidal space lasts for 90 days. But from the clinic, and that was upon one single dose or one single concentration that they used in the pig model. But in the trials that we started using triamcinolone in macular edema, we went through 3 different concentrations. Clinically, we can say that it lasts up to even 6 months by putting it in the suprachoroidal space. The absorption happens to the fluid part of the triamcinolone. And if you look in the OCTs, you find that there are 2 components once you inject them there. You can see the fluid component and the particles. The particles usually last maybe in 4 months in OCTs if we can follow up. Once they start getting smaller, sometimes we can't locate them with OCTs. But clinically, we've seen an effect lasting maybe up to 6 months by putting it there. The comments about the silicone, I definitely agree that you could inject around the silicone bubble. But the question is, an anti-VEGF is an antibody. Does it have the same activity if it was contaminated by silicone? That's the question. Maybe for steroids, it is there. But antibodies like anti-VEGFs, I'm always concerned about the activity of the drugs once we inject them in silicone.
Yeah. So we all, hi, Andre here. We all know that you're the king of the catheter. And honestly, like, there is one person in the world that knows how to do it, that's you. But there is a learning curve. Like we, all humans out here. But, Is there like a true need to inject that posterior? What do you think? Because it would be a little bit easier to use the catheter and place on the suprachoroidal space, but not not go that far to the posterior pole. Maybe to leave at the equator area or whatever. What do you think about it? Would it work or would it not?
Excellent comments. Well, I must say that the catheter itself is not a difficult procedure to do once you're doing it in emmetropic eye or a normal eye, not a thin choroid, not a very high myope. I mean, pushing in the suprachoroidal space is not difficult as it seems to be. So that definitely is a learning curve. The question about where do we need to inject the drug is always a question that I ask myself even. Before, we were always targeting underneath the macula. In these two videos, I was injecting at the arcade. When we started putting implants like alluvial implants in the suprachoroidal space, we found that even if you put it around the equator, if you just put it in the suprachoroidal space around the equator or a little bit further than the equator, it has the same effect than putting it underneath the macula itself. So because this is a more slow release implant. But having a bolus dose, usually you try to come close to the pathology like in macular edema, gives you a more faster absorption time and a longer lasting effect. So the thing is, how fast you want to have the drug effect, then you definitely have to come close to the pathology to have good diffusion of the concentration of the drug at the target tissue.
Yeah, very good. I love your presentation. That was great. And we are approached the end of our meeting. We are now around 2 hours speaking. And now we have time, each one of you that represent societies, meetings, and we start with Ehab. Want to say some word about the Cairo Retina meeting?
Well, the Cairo Retina meeting has been going since 2000, and I'm sure that we have a lot of faculty already on our panel here that used to join the meeting since then. And we are proud to join the Retina World Congress in working together and bringing exchange and knowledge from all over the world, especially the Middle East region, joined by the Arab African Society to join the Retina World Congress and have exchange of knowledge, exchange of information from people all over the world. So we're looking forward to joining the Retina World Congress from the Arab African Society as well as the Cairo Retina meeting.
Jorge, are you listening to me?
Yes, very good.
You know, for Uruguay, it's a very good opportunity. We are some few ophthalmologists here, behind Brazil, behind Argentina. That are so many people there and so well capacitated. So it's very important for us to do this kind of meeting and can participate. So I would thank you very much for that.
Thank you, Miguel. It's very important to have the Uruguayan and all the colleagues there together. I hope we can see each other in the near future in the Retina World Congress in Florida. But it's very nice to have you here. I'm very happy and honored your presence. And now we have the president and the president of all Indian societies.
George?
Want to say some words?
George?
Yeah, I can hear you well.
Okay. So I just, on behalf of All India Ophthalmic Society, I thank Tarek, Debbie, and George for having us. And I remember our last board meeting, and then we were supposed to do in December, but we finally did it in May. We have 23,000 ophthalmologists in India, and everybody knows about it. But unfortunately, we call it like a webinaria because there are too many webinars going on in India, and I think there are about 40 webinars a day. And unfortunately, it was overlapping with the cataract webinar right now, but still, it's recorded, and I think it's also there in the Facebook Live. And thanks for the opportunity. And I know that through the Facebook, through we are also going to All India Ophthalmic Society said, so doing it parallel, we'll have the recording and put it in the AOS YouTube also. So I hope all our members, and we also informed our Retina Society of India, who's also part of All India Ophthalmic Society. I'm sure many are watching this, and thanks for the opportunity, and it's a great learning. I enjoyed every presentation, and all friends to see happy again, even though we can't meet in person, but I'm happy because I think I was traveling 2 days a week, and now totally no travel for the last few months, and I think this is a great opportunity. Thank you all.
Thank you very much, Nuri. I think Tarek wants to say some words too.
Well, I just, on behalf of Retina World Congress, want to thank all of you who are watching, and most importantly, our contributing societies. and their leaders, and the KOLs that have served on our panel of Fernando and Maria and David and Andre and Carlos, and everyone who's brought such wonderful knowledge to us, as well as our society representatives. And it's just a fantastic opportunity for us all to get together. Hopefully one day soon we'll all come out from this and be able to see each other live. But I think we'll be left the lasting legacy of being able to communicate online with these educational opportunities. And the Retina World Congress, we hope, will be one of the platforms you go to as the one that can really unite the world's societies, independent of where you belong and what region of the world you live, to disseminate this information out there. So again, we appreciate your contributions very much. And George, thank you especially for the Director of Communications, a master who kind of controls all of this and brings it together. So thank you all.
Thank you all. It was wonderful to share my Sunday with you and with all the attendees around the world. And have to special thanks the people behind doors like Tiago, Fernando, that's helped us with technical support, and Debbie, that's do all the hard work to keep all the people together. Thank you very much, everyone. I have to say that was wonderful, but next month I hope you can stay together because we're gonna have another very, very good RWCE Live that's gonna be prepared, very special from all around the world. I think Fernando Aravello wants to say something.
Thank you, Jorge. I just wanted first to thank the Retina World Congress for the opportunity. I really enjoyed seeing and learning so many great friends. But at the same time, I'd like to, on behalf of the Pan American Association of Ophthalmology, invite you all to our Pan American virtual symposium that is happening every Monday at 4 p.m. Eastern Time. We're having that symposium until June 9th. So every Monday at 4 p.m. Eastern Time until June 9th. And the information to log in is available at the Pan American website at paao.org. So please join us. We're going to be touching upon all different subspecialties, not only retina, and I'm sure you're going to enjoy it. Thank you. Thank you so much again for the invitation and the opportunity. I really enjoyed it.
Thank you, Fernando. It was very nice to have you here. And I guarantee the Pan American web meeting is very nice. I participated many times. I was attending many times. I guarantee and I ask everybody to join us because it's very good. And now Carlos Mateos from Spain want to say something.
Thank you very much for having me here. It's great to share with you all of our ideas and different, perspectives. And thank you very much for your great organization. And my best regards to all of you. That is our friendship is forever, And stay safe. Very important. Stay safe.
Well, I want to thank the Retina World Congress because it has, they have really brought all of us together in, a very encompassing worldwide fashion, more than any other meeting. So thank you again to Jorge, to Tarek, and to Fernando for organizing all this. And it's great to see you all. Thanks.
Derek, you want to close?
Well, certainly, yes. I will let you all go out to enjoy what's left of your day or go to sleep if you were far away, Nutty, for tomorrow. Thank you all for being with us, and we hope to see you soon. And we'll look for you next month, and we'll see you soon. Take care. Have a great day, and thank you all.
Thank you.
Bye, everybody.
Bye, everybody.
Bye.
In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the retina world community.